Hello, welcome to our SOC 225 final lab project created by Gabby Fong, Nathan Nguyen, Gabrielle Rackner, and Rory Thompson. We received the dataset from Kaggle, and in this project, we will go over the availability of hospital beds in the U.S. during quarantine and COVID-19.
We chose this question to gain a preliminary look at COVID-19 preparedness in the United States. Thus, we would be able to provide context for understanding United States public health outcomes and our response. More specifically, we wanted to know, how do the number of beds vary by state or region? How do the number of hospital beds relate to the amount of cases in a state or locality? And is there a shortage of beds compared to the number of cases we expect to see in each region? In order to answer these questions, we've chosen a dataset that estimates expected demand based on expected COVID-19 case numbers in each region and existing static levels of bed availability.
In graph 1, it labels the total number of hospital beds by state, the x-axis being the states in America and the y-axis being total number of beds per state. According to the graph, all states will not exceed over 60,000 hospital beds besides California. The trend seems to be that the higher the population the state has, the more hospital beds are in that state. Take California and Texas as examples, both of the highest amount of hospital beds with the highest population also. Although there's a limitation to this graph, because it never accounts for how many hospital beds are occupied at the time or how many are reserved for certain types of departments, appointments, or any type of others. Also, another type of limitation is reading the total number of hospital beds in a state that are extremely lower. For example, anything under 10,000 hospital beds gets hard to read on the scale, like Alaska or like Arizona. We had to determine the total hospital beds per state to later predict if we will have enough hospital beds for the projected amount of COVID-19 cases per state.
And the intention of graph 2 was to analyze the relationship between the total number of hospital beds per state and total number of coronavirus cases in each of those states. From this graph, you can see that the relationship between the two variables is a positive correlation, although it is a nonlinear relationship. As the total number of hospital beds increases, the total number of coronavirus cases increases as well. But from the trend line, you can see that it could be a linear relationship, but then it somewhat levels off, possibly due to the New York State data point. A possible explanation for the positive relationship is the population of each state, which could be the possible confounding variable in this relationship. When the population increases, it can lead to a higher number of hospital beds needed in general and a higher number of people that could be infected with coronavirus. The limitation of this graph is that the data points are not labeled, so you would need to reference graph 1 to know which data point represents which state.
We investigated how hospital beds varied across the United States during COVID-19, and if there was a relationship between the number of cases in the state and total beds. We found that there tends to be a shortage in beds versus the number of cases, which has resulted in healthcare workers scrambling for supplies and being overwhelmed with too many patients and not enough beds. We also found that states with a larger population tended to have more hospital beds in their state. States with higher populations but less cases, therefore, could lend beds and perhaps supplies to those states that are overwhelmed more. But although this seems like a good idea, there is also a slight positive linear relationship between total cases and total number of hospital beds. This is probably because those states with more beds have a larger population, and therefore COVID-19 can spread much more quickly in densely populated areas, resulting in a higher number of cases, like New York. Our research does not raise any privacy concerns since we are not given individual patient data, rather a number of cases or beds and the corresponding location, which allows for complete anonymity. There are some limitations to our model, though, which is due to the datasets themselves. The COVID-19 dataset uses positive test results by county in the United States over a 3-month period, which means that when we say total cases, we're referring to total accumulated positive cases over this 3-month period. Also, we are assuming in our research that the majority of hospital beds are being used for COVID-19, or that our model implies that if they are being used for COVID-19, there tends to be a relationship between hospital beds and cases. So our graphs don't represent instantaneous data, which allows for us to see a full picture of the relationship between cases and beds, but does not provide for a real-time analysis.